Hello everyone and welcome again. So continuing our discussion about the orthopedic trauma basic principles class, here we will talk about the stress fractures, which also known as the fatigue fractures. So those fractures are most common in athletes, and here we will talk about definition, risk factors, affected bones, clinical features, imaging, and treatment of stress fractures. So let's start. Let's start with the definition. So a stress fracture is a fracture that occurs due to small repetitive stresses, minor traumatic events or incidents that occur repetitively, and those repetitive stresses lead to osteoclastic resorption of the bone, exceeding the osteoblastic formation, and a zone of relative weakness develops, leading to a fracture. And the repetitive stress could be either a bending force, or it could be a compressive one, or a combination of both. Risk factors for stress fractures include athletes, as we mentioned, dancers, military recruits, because they build up muscle power quickly but bone strength slowly. So this would lead to their bones being affected by the muscle power and lead to stress fractures. And people with osteoporosis or osteomalacia, and patients treated with drugs that affect bone remodeling, example corticosteroids, methotrexate, and bisphosphonates. And the female gender is more susceptible to these fractures, and low vitamin D levels also. Now let's talk about the affected bones by stress fractures, and those mostly are the lower extremities because they are weight bearing, and if the patient is doing vigorous exercise, this would lead to those weight bearing bones being repetitively injured, and it would lead to a stress fracture. And the most common bones to be affected by stress fractures are the metatarsals, especially the second metatarsal fracture. It is the most commonly affected bone, and when it fractures, it's called the March fracture. Then comes the navicular, the calcaneum, the fibula, the tibia, the patella, the femoral shaft, the femoral neck, and pubic rami. And it could also affect the fifth lumbar vertebrae and the shaft of humerus, but those are rare. The most common are the lower extremities, as we mentioned. Clinical features of stress fractures is that the patient is healthy, there is a history of repetitive strenuous activity, and the patient present with insidious onset of pain starting after exercise initially, and then the pain progresses and it becomes even during exercise, and then it progresses to pain even without exercise. The patient describes a similar history to this. The patient usually present after the fracture has healed and may complain of a lump, which is the callus that is formed as the healing process, and on examination, on look, the affected site is swollen or red, warm, and tender. The callus may be palpable sometimes, and feeling the bone is result in tenderness over the fracture site. Now let's talk about imaging. So early on, the fracture is difficult to detect on plain X-ray, but if you retake the X-ray after a few weeks, it would show the defect with callus formation, and radioscintigraphy will show increased activity at the painful spot, and the MRI show the fracture very well even at early stage, so it is confirmatory test. So here we have plain X-ray images of stress fractures. So on the left you can see the fracture line, but you can see the periosteal reaction as the callus formation on the radius, so indicating that there was a fracture here and it healed. And on the right picture we can see the second metatarsal fracture as we can see here, and it is already healed, and this is also called the march fracture, as we mentioned. And here we have an x-ray for the ankle joint, and there is no fracture line on any of those bones, but when we did MRI, we can see that we have a fracture line here on the talus bone, but here it is not visible on the x-ray, but on MRI it's very well visible. Treatment of stress fractures include elastic bandaging and avoidance of painful activity for 2 to 6 weeks, except in femoral neck stress fractures. If confirmed with MRI, it has to be fixated with screws. And most patients benefit from calcium and vitamin D supplementation. And that's it for this video. Thank you guys for watching. Please make sure to like and subscribe. And if you want to support more, you can by subscribing to the Patreon, link provided in the description of this page. Thank you for watching, and peace.